Hey everyone, I'm Hannah Harvey, and today I'm presenting my study proposal for identifying associations between vitamin B12 deficiency and periodontal disease. The aims of the study are to investigate and discover possible links between the two conditions, and so as to contribute to scientific knowledge, to educate health professionals and the public, and to ultimately promote public health. And while the human body can't synthesize its own B12, we have to get our B12 from the diet. So microorganisms can actually synthesize B12, so B12 becomes more saturated as we go up the food chain. For example, crabs eat microorganisms, and then we eat these B12-rich crabs. So the best sources of dietary B12 are actually meats and seafood, but you can also get it from dairy, fortified foods like breakfast cereals, and multivitamins or supplements. And B12 is vital for our bodies. It provides, it's a coenzyme used in a myriad of reactions within the body, such as proper red blood cell formation, in DNA and RNA synthesis, and in the construction of myelin sheaths around the axons of our neurons. And while it's a water-soluble vitamin, it can actually be stored in our bodies for up to several years. So it's understandable why individuals who are deficient in B12 commonly develop conditions like dementia, oral lesions, and anemia. And if any of you are Downton Abbey fans, you'll remember Lord Merton, who became ill with pernicious anemia. The treatment for which really wouldn't be discovered for another couple decades, so maybe he just needed a little more meat on his plate. But anyway, there are a lot of key factors that contribute to B12 absorption, so any problems with these key players can contribute to malabsorption. In relation to this study in particular, I want to point out certain key players in B12 absorption. Normally, our saliva and stomach produce proteins called R proteins, or haptocorins, also known as transcobalamin 1. Which help transport B12 through the small intestine for absorption. When food-bound B12 enters the stomach, it meets hydrochloric acid and pepsin, which breaks the B12 apart from the food protein and allows it to bind with the R proteins for transport through the small intestine for absorption. It also binds with other transport proteins such as intrinsic factor, which actually brings it to the brush border for absorption in the enterocytes. And then it is then dissociated from intrinsic factor and attaches to transcobalamin 2, which brings it through the portal blood for use or storage in the liver. So, but the key players that I want to focus on, it's a complex process, but the key players that I want to focus on for this study in particular are hydrochloric acid and R proteins. That will become clear in a minute. So let's look hypothetically at an 80-year-old man. There might be a few reasons why he actually can't absorb B12 from his food as readily as the rest of us. He might be taking medications like metformin or memantine, which are drugs used by individuals with type 2 diabetes and dementia, respectively. And these can cause reduced saliva production, also known as xerostomia, thus reducing the amount of R proteins readily available to bind to B12, and xerostomia can contribute to bacterial proliferation. In particular, Helicobacter pylori, or H. pylori, is a gram-negative bacteria that has been associated with atrophic gastritis and dementia. If this man has atrophic gastritis, or if he's taking acid-suppressing medications like proton pump inhibitors, both could reduce the amount of hydrochloric acid necessary to free B12 from food proteins, so this could contribute to malabsorption. But also, maybe he has trouble eating certain foods, or maybe he can't chew or swallow very easily anymore, or maybe he doesn't have access to B12-rich foods because he either can't cook or shop easily on his own, or maybe he can't afford it. So it's really not hard to see why the elderly are a high-risk population for deficiency. Now, we've established that the elderly are at higher risk for B12 deficiency, so they're really an ideal subject population for this study, but they're not the only ones who could benefit from this research. With the vegan diet on the rise, for example, there are many individuals who may be going vegan who aren't supplementing properly and who may not even know that they aren't getting enough B12 for several years when their reserves finally empty. B12 deficiency can also occur in individuals with autoimmune or genetic disorders that contribute to malabsorption, in individuals who abuse alcohol, and in bariatric surgery patients, for example. And so for this study in particular, adults over the age of 65 are of particular interest because B12 deficiencies are commonly reported in this older population, and it just so happens that this population experiences greater instances of periodontal disease. The American Academy of Periodontology estimates that about half of U.S. adults over the age of 30 actually have periodontal disease, so that's a lot. And these cases actually are increasing in individuals over the age of 65. Let's go back to our example of our hypothetical 80-year-old man and in relation to periodontal disease. Now, if he's taking certain medications, or frankly, if he's dehydrated, this could contribute to xerostomia, which could lead to bacterial proliferation and dental caries. Plus, if he has a certain level of cognitive impairment, he might not be as mindful of taking care of his teeth, of his mouth, of his oral hygiene. And in fact, one longitudinal study of over 500 participants, which I found extremely fascinating, demonstrated an association between the progression of periodontal disease and the reduction in cognitive function in older men. And over the course of this 32-year study with periodontal exams performed every 3 years, researchers actually found that participants' cognitive function worsened with increased tooth loss. And other research in geriatric hospitals has shown that many elderly patients are malnourished, and this can include obese individuals. One clinical study in particular found that 88% of obese subjects exhibited periodontal disease, and this actually increased to 100% for subjects over 60 years old. Research has also shown connections between diabetes and periodontal disease too. So it's easy to see that there's an intricate web of possible connections between symptoms and causes of B12 deficiency and periodontal disease that are co-occurring in elderly populations, and it's really enough to warrant further study. So for this experiment, we'll conduct it at various VA hospitals in the US, and there are actually over 200 VA hospitals that provide dental care on top of general medical care. So ideally, these will be the facilities that will be used. And according to the sample size G-Power recommends using an a priori calculation for a t-test of dependent matched pairs, this study will require a minimum of 45 subjects, but ideally we really want our pool to be larger to hopefully enhance the reliability of our findings. We'll recruit our volunteers through VA hospitals and American Legion locations, through bulletin posts and newsletters and email blasts, and primary care providers at participating VA hospitals can also ask their patients if they would like to volunteer in the study. For homogeneity's sake, we'd like to keep the subjects males over the age of 65 who have a B12 deficiency and periodontal disease. So this study will exclude individuals that don't meet this inclusion criteria and anyone who has received B12 deficiency treatment within the last 3 years. After obtaining informed consent from all subjects and or their caretakers, participants will complete a number of surveys that will give us demographic information, information about their oral hygiene habits, their nutrition, and their mental state. And medical professionals like doctors, nurse practitioners, dentists, dental hygienists, registered dietitians will assess subjects before treatment begins to record baseline values and to ensure that they are able to participate in the study. Blood and stool samples will provide us with important information about B12 serum levels, along with a few other important blood markers. And stool samples will provide us with H. pylori levels. The subjects will be treated within a year-long period of time, after which they'll be fully examined again to identify any changes since their pre-treatment exams, and hopefully we'll see some oral improvement. And this treatment protocol is based off of a study, another study where geriatric hospital patients were actually being treated for a B12 deficiency. So similarly in our study, subjects will be given 1,000 micrograms of B12 per day for 15 days, then 1,000 micrograms every 10 days for a month, and then 1,000 micrograms per month for 3 months. And at each stage, we will reassess their medical and dental status, as well as their oral hygiene and nutrition and mental state through the surveys. And after 1 year after treatment was started, we'll again re-examine them to see if anything has changed. As compensation for participation in the study, the medical and dental exams and all required lab work will be complimentary for all participants, and safety precautions will be put in place to protect subjects' privacy and personal information. All participants will be given a code for their name, so they will be kept anonymous, and all data and code keys will be kept secure in digital spreadsheets, either on secure servers or offline on off-site computers that are password protected, that are only accessible to the research team. Data will be analyzed from each evaluation and compared using t-tests to compare the means of dependent matched pairs. In other words, the mean values pre- and post-intervention will be compared for each subject to identify any significant changes from the intervention. We will test for significance at alpha level 0.05 or the confidence level of 95%. The p-values at or below 0.05 will reject the null hypothesis that there's no association between the two conditions in elderly males in the US. And chi-square tests will also be used to analyze all surveys and periodontal assessments. And the benefits really outweigh the risks in this experiment. Patients may experience some temporary discomfort during dental exams, depending on the severity and manifestation of their periodontal disease, but no other risks are predicted for this study. Benefits of the study include potentially providing new and pertinent health information for health professionals with the hope of providing and preventing health conditions that may be associated with vitamin B12 deficiency and periodontal disease, not just for the elderly, but for other at-risk populations too. Ideally, this study will contribute meaningful and helpful information for the scientific community, to health professionals, and for the health of all populations that are at risk. So, thank you.